Okay. That one at least I remembered was June. So next topic we're going to go through, the real national registry topic is MI. That's about 10 minutes of topics to really cover MI from a pre-hospital ED level. So thought it was a good opportunity to add in EKG review, basic 12-lead interpretation, and some rhythm reviews. Just we haven't done that for a few years. A good refresher. So feel free to stop and ask questions since I have a lot in this one. So understand basic EKG interpretation, basic EKG abnormalities, EKG findings of acute coronary syndrome, current treatment guidelines for ACS. Well, I don't have in here, but we'll go through a little bit about what the Mission Lifeline is doing now, and to review our current ACS protocol and chest pain protocol. So we all remember this from beginning of our education, normal conduction system. So everything kind of starting up in your SA node, down through your AV node, and then down through your bundles. So when you find your blocks, you got to think about where it is along your system as to why you would see what you see on your EKG. And the most common blocks that you're going to see are your left bundle branch block and your right bundle branch block. So just kind of have that visual of where those need to travel when you're looking at your heart vectors from your 12 lead that we'll go through. So basics, just lead placement for your limb leads. You all know this, but just kind of refresher of where you should be upright with your QRSs and where you're down going. So there's your standard limb leads with your axes. And we'll get to axis deviation and what it means. I know that's kind of the worst part about interpreting EKG is your axis. Doesn't mean a lot in most cases, but when you see your printer at the top of your EKG print out axis deviation, you at least need to know what that means and why you might be seeing that. Because some of them can help clue you in onto what's going on. So the important thing is here's kind of your normal axis that we'll go through. So have to be positive in 1 and AVF sitting down here, and 2. And all your negatives are up here. And then you're looking at your precordial leads. That's kind of the view when you put those stickers on, what that is seen, where that vector is coming from. So that plays into when you're having an MI, why it's seeing what portion of the heart that it's actually picking up. One thing I wanted to point out is when you put these on, you have to make sure you're getting down to the chest wall. I've seen them placed both by ER techs, medics, nurses, clear up because I don't want to deal with women and breast tissue and moving, but you have to get it down on the chest wall. Putting it on top of breast tissue can really alter your vectors in your EKG. So just FYI. So there's through your anterior septal, your anterior lateral leads, inferior, and inferior lateral. There's no good way other than when you look at your 12 lead knowing where your distributions are, but these are something you need to know. Where your MIs are, what leads. And I have a nice little color version of this later when we get into the MI. So basics of interpretation, you need a systematic approach every time you look at a 12 lead. If you get in the practice of every time you look at a rhythm strip, you look at a 12 lead, rate, rhythm, axis, then you're looking for hypertrophy and ischemia. But in your rhythm, you're going to look for all your blocks, look at your intervals. So just have to have a systematic approach, because if you're just looking at what the monitor says or your printout, you'll miss some big important rhythms you're not going to pick up because you guys can be smarter than what your monitor tells you. So you look at it, but you've got to have a systematic approach to looking at your rhythm strips and your EKGs. I assume everybody here has learned the simple way to determine rate, because sometimes your monitor will be telling you one thing and you look at that and you're like, that is not what I'm seeing on the monitor. So easy way to do it. You can memorize the 300, 150, 175, 60, 50, 43, and go through, but you just divide by the number of boxes between each QRS. 300 divided by that number of boxes. So if there's 5 boxes, your rate's 60. So what's your heart rate here? Don't cheat and look at your handouts. So 1, 2, 3, 4, 5, 6. So, or if you have it memorized, you know the 300, 150, 175, 60, 50. But divided by your number of boxes. And that's going to be more important when you're trying to look at complete heart block, because it's only going to pick up the ventricular rate in a heart block. It's not going to pick up your atrial rate. So you can do the same thing if you have a complete heart block and you're marching out your P waves. You want to make sure, because you'll have a different atrial rate than a ventricular rate in a complete heart block. So kind of a simple way. A lot of ED gurus do not like it. I want you to actually calculate, but simple way. So what's the rate on this one? 150. 2 boxes. So by definition, tachycardia is anything greater than 100 in adults. And remember, your peds is not going to follow the same adult numbers. So kind of a rough estimate is 180 in a 1-month-old. 100 is by a 12-year-old. That's when we start to get kind of in the adult sizes. Although anymore, some 8-year-olds are adult size. So just remember that when you put on your monitor and you see 140 in a 2-year-old, that's going to be a normal heart rate. And this is a little bit of your ACLS differential diagnosis of your tachycardias. So is it narrow? Is it wide? Is always the first thing you're looking at. And is it regular or is it irregular? So most common, regular, narrow complex, your sinus tachycardia, your SVT should be regular, should have no irregularity to it. And an atrial flutter that's like a 1-to-1 or 2-to-1 is going to be very regular. It will look very similar to SVT, and we'll go through one of those 12 leads later. And then irregular is going to be your AFib, A flutter with variable conduction. So it's not the classic 2-to-1, 3-to-1, 1-to-1. It conducts at different rates. And your multifocal atrial tachycardia. And your wide complexes, your sinus tach with your aberrancy. So all these have these weird aberrancies that have escape beats, and your VTach should be regular. Your VTach that should be VFib on that bottom one, sorry. And then AFib with aberrancy and AFib with WPW. So just a basic review of your 12 lead and what is each interval. You've got your sinus rhythm, so that means they have a P wave. It's coming from your SA node. So there's your P. PR segment is that rest in between your atria, your ventricle. Remember, your atria is repolarizing in the middle of that QRS, so you don't see it. Your ventricle depolarizes as your QRS complex. And then your T wave is your repolarization of your ventricle. So your PR segment and your ST segment, those are kind of the big ones you need to look at and know if they're long, short, elevated, depressed. And here's kind of a depiction of what's happening electrically at each point in the 12 lead. So you think about why you get a long QRS is taking ventricle longer to depolarize and get through that entire ventricle, like in a left bundle, right bundle, longer to move down that electrical conduction system because there's a block somewhere. So it has to go not through the normal pathway, but through the myocardium itself and not on the electrical circuit. And that U wave, I don't know if any of you have actually seen a patient with it. You'll see it in hypothermia and some electrolyte abnormalities sometimes. So tell me what rhythm this is. Don't look at your seats. So when you look at it, what's your rate? 300, 150, right around, just under 100, right? Just over 3 boxes. Okay? So, is there a P before every QRS? And is there a QRS after every P? And is it regular or irregular? Okay, so you have just normal sinus rhythm. And you never memorize all these. Even I have to kind of sit and think about my QT duration. But just so you kind of have an average, so when the computer's spitting out something, you know, here's what the normal and what's it's basing off of. These will change a little bit in pediatrics, but for adults, these are your normal intervals. So often it's like you look at your 12 lead and say, that doesn't look quite right. Something's longer than it should be, and that's when the computer will calculate for you. You shouldn't have to be calculating your own intervals. The monitor will do that for you. So the biggest prolongation we worry about, you can get prolonged, PR with a first-degree block. Not as important as your prolonged QT. There's a lot of drugs that can do that. Sodium channel blockers are the main one. There's also a lot of psych drugs out there that'll do this. It's a big thing with Haldol and a lot of the other antipsychotics is they prolong the QT. Hypocalcemia, hypomagnesia, hypokalemia, so all your electrolyte abnormalities when they're cold. So you get this in a hypothermia type drowning patient who's cold out in the elements, or when you induce hypothermia, you'll start to see this potentially on their 12 lead if they're up being cooled. Acute MIs. And the congenital ones, that's the one we worry about with the sudden cardiac death is prolonged QT. That's the whole theory of why we need to do 12 leads for athletes, and do they have a family history of sudden cardiac death. And you can actually get this from a neuro response from a head trauma, head bleed, anything that increases the intracranial pressure. So women have a little bit longer QT interval, so 450 to 460 milliseconds. And the computer will correct it for you, too. You don't have to learn that. So blocks. That means somewhere there's a block in that AV node down that pathway. So first degree means just your PR is a little bit longer than it should be. Very little clinical importance in that. See it a lot in your COPDers. Second degree, Mobitz 1, the good old Winky Buck. Mobitz 2 is, so in the Winky Buck, you'll have your PR gradually lengthens. So you have variable PR and variable QRS. So gradually lengthens out, your PR interval gets longer, 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 you drop a QRS, and it starts over, longer, longer, and drop. Whereas second degree, you'll have your PR intervals the same every time, except for when just a QRS disappears. So otherwise, all the ones that have a QRS following a P have the same PR interval. Which one's worse? Right. Type 2 is the worst, besides type 3 block. So that's a complete dissociation. So that's what I was talking about when you need to be able to calculate your atrial rate and your ventricular rate. You can have an atrial rate of 300, but you have a ventricular rate of 20 with complete dissociation. Those are bad too. So type 2s and type 3s typically need a pacemaker, AICD placement. So what's this rate and rhythm? What's that? So tell me what your ventricular rate looks to be. So your P, do you have a P before every QRS? And do you have a QRS after every P? And that doesn't show up. My mouse doesn't. What does these look like? And what's this? So, P, P, P in your T, P, 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 P. Are those regular? So you have a ventricular rate that's like 20, and an atrial rate of 300, 150, 100. So what is that? So complete heart block, complete AV dissociation. You've got an atrial rate and a ventricular rate that do not correspond to each other. Okay, what about this one? Yep. So you got a Mobitz 1 because you've got PR, PR lengthening, dropped. Starts over. So, linky buck. What about this one? Anybody? Yep. So, and why is that? Yep, your PR. Yep, PR is the same in everyone, and it just drops. QRS is here, here, and here. What do you see in this one? Yep, because your PR interval is greater than the 0.2. So just prolonged here. And for the love of God, don't ever tell a patient they have a long PR interval. They'll be all distressed about it, and it really means not much. So just tell them it looks good. So axis, the dreaded axis. Like I said, it's, I'm not asking you guys to calculate axis in every patient, but at least when it reads out left axis deviation, right axis deviation, or indeterminate axis, you need to know what that means. Do you have your leads on right? Kind of the safety check on that. So your axis is basically the overall direction of your electrical activity of your heart. Normal, the reason that normal is clear down over here is because if you picture your heart laying on here, left ventricle, biggest part of the heart, is sitting down here. So the overall axis should be heading in that direction. So if you're clear up here, that means there's more of the heart sitting up here. So we'll go through all the reasons, but that means your vector's heading up that direction. Right axis means it's taking longer for that electrical activity to get over here. Up here means you either have your leads on wrong or they've got some weird kind of heart transplant, prosthetics. You should never really be up here. If it's up there, something's very wrong with their conduction system or your leads are in the wrong place. So kind of just a depiction. One way we kind of learned it is looking at 1 and AVF. That 2 thumbs up sign. So if they're both positive in lead 1 and AVF, that's your QRS. That the most of it is above the isoelectric line, then you're on a normal axis. So obviously if you're negative in your AVF, you have left axis, you're up here. And if you're negative down here in your AVF, then you're up over here. So just a basic, if you look at 1 in AVF and they're both in the right direction, thumbs up, QRS is both going up, you have a normal axis. So kind of a quick, easy way to look at it. So causes of axis deviation, your left that we talked about, it's kind of off, up to the side. You have LVH, and an inferior MI will do that. A left bundle branch block, a left anterior fascicular block. So remember your pathway. It's taking longer to get down that pathway, so it has to move through the myocardium rather than through the normal conduction system. So that axis deviates up and to the left because there's just more to travel through that direction. Or a horizontal heart. So you can get these congenitally, diaphragmatic hernias and other deformities from birth, or the way they've had to transplant in. Very rarely will you see that, but a few of those congenitals. And right axis is kind of almost all the opposite. Right ventricular hypertrophy, a lateral MI, your right bundle branch block, pulmonary hypertension because that right ventricle is enlarged, like we talked about in the CHF. Pushing against it, right ventricle is much bigger, so it's going to deviate that electrical activity over to the right. A vertical heart, sitting much more straight up, and a PE. So kind of number one cause that we see acutely in the ER is PE that you look for, is do they have a right axis deviation, and they didn't have one on a previous 12 lead. So your classic right bundle branch block, we all know the rabbit ears. So right rabbit, they have two little notches here. So that means it goes down the normal pathway through the left bundle, depolarizes the left ventricle, but that right ventricle can't go down that normal pathway. So now it has to go through, from myocyte to myocyte, through the myocardium. So it takes longer to depolarize up that entire right ventricle. So that's your depolarization of your right ventricle. So that's why you get your two little bunny ears, because the right ventricle is taking longer, and it's smaller than the left, typically. In your left bundle branch block, you go down here, depolarize your right, but your left is so much bigger, it stops here, now it has to travel across myocytes all the way through and depolarize this entire left ventricle. So if you have a high left bundle, it takes out that entire thing. That's why your QRS gets longer, much wider, takes so much longer to get through. This is all of that trying to get through that a big left ventricle because it's not going down the normal bundle. So an MI decreases blood supply to that area, can take that out, or your hypertrophy and all your other things that are going to make that left ventricle big. And a new one, new left bundle, instead of chest pain or other fatigue symptoms, is MI until proven otherwise. So now we're going to go through some practice 12 leads with some symptoms. So 32-year-old female with chest pain. What do you see here? What's your rate? Is it normal, fast, slow? So 1, 2, 3, 4, 5. What's 300 divided by 5? So, normal rate, right? Now, is it regular? It's not a perfect rhythm strip, it's all the leads down here. But is it regular or irregular? Okay. Now you look for any blocks. Do you have normal PR interval, normal QRS, and do you have a P before every QRS and a QRS after every P? So this one's simple. Yep, normal sinus rhythm. Start easy on you guys. So, 76-year-old male with dyspnea. Is your rate fast, slow, or normal? One, two, three. So just under 100, probably like 98. So upper limits of So, is it regular or irregular? Okay. Look at your intervals. Yep. So you have a long PR, and then you have a P before every QRS and a QRS after every P. So you have sinus rhythm with a prolonged PR interval. So it's kind of your classic COPD or might have a increased PR interval. Again, don't tell him. Okay, 48-year-old female, lightheadedness with walking. We haven't really talked about this rhythm, but you should know it. Okay, so she's Brady. Okay, so if she has no P's, that means what node isn't firing? Okay, so what is that rhythm? Yep. So that's why she's lightheaded. She's in a junctional rhythm, and she's slow. So, did she have an event that took out her SA node? That's what our job is to work up and figure out. But you at least know this is not a patient you would send on her way and release because she's feeling better once she sits down. – 50-year-old female, sudden onset of palpitations and dizziness. Do you rate fast or slow? Okay. Is it regular or irregular? And is there a P before every QRS and a QRS after every P? Okay, so what do you have? Yep, AFib with a rapid ventricular response rather than a controlled rate. You're in a rapid rate. So, I don't have it in here, but what drug might you give? Yep. Another drug you could try is a beta blocker if they're not bad COPD or asthmatic. "86-year-old woman with generalized weakness." So is it fast or slow? Right, depends on what segment you look at. So is it regular or irregular? Now look at your intervals. And it's best if you look at, obviously, your rhythm strip at the bottom here. So P, QRS, P, QRS, P, QRS. So what is that? Anybody? So short, a little bit longer, a little bit longer, a little bit longer, drop. Anybody? Yes. So, Mobitz 1. 24-year-old male, sudden onset of heart racing. What's your rate? So you have one box pretty much. So what would that be? 300 divided by 1. 300. So, you're tachycardic. Are we regular or irregular? Okay. So what gives you a regular rhythm, narrow complex at 300? SVT. What drug are you going to give? Okay. What's your dose? Very good. 6 and 2 12-packs to go. Okay. Here's one very similar. 72-year-old female. She's dizzy. She has never had any cardiac history. She's never had an ablation. She's never been on cardiac meds. She's never had an MI. So this looks kind of similar to that one, right? It's fast. It's regular. But she's 72. So you give adenosine because you think she's a narrow complex, regular tachycardia. And that's what you see. So what was she? What was she here? You give adenosine and you go into flutter. Bill? So if you give adenosine in that, and then you see this, what is she? What is this? I have the answer up there, but. So when she was, back here, she's probably a 1-to-1 flutter. So just something to think about after doing this for a long time. Old people with SVT who have never had, they don't say I've been ablated 5 times, I'm on cardiac drugs for my rate control, I've been on verapamil and all the other antiarrhythmics. A new onset 60, 70, 80-year-old with SVT looking EKG, you can give adenosine, you're not going to hurt them. But you'll often see this when you give it, because they're a 2-to-1 or a 1-to-1 flutter. So when you see this, you abort your adenosine, because you're not going to convert them with adenosine. You just slow down their rate enough to see those underlying flutter waves, because you slowed their ventricular rate. But that's why, if you imagine this EKG, if you had a QRS following every P wave, you would start to see the same EKG you did before. So just kind of a thought process to think about, that when you have had this many, many times where the nurses bring you this SVT, prints out SVT on the computer, and they're 82, and they're short of breath, and they're tachy, and they want to pull the adenosine. I'll go to cardizem or a beta blocker, and you'll see this. So 2-to-1, it's half their normal ventricular rate. So if you see a rapid rate at 150, divide that in half, because it's 2-to-1, you get your resting ventricular rates. So just a little education piece. It often will. Other times might slow it down enough for a while to see the flutter, but typically as that wears off, it'll kick back up. So that's why we always hook them up to the rhythm strips while you're doing the adenosine, because often you'll pull out whatever underlying rhythm they have that then you'll change to treat, because you've slowed that ventricular response just down enough that you can see their underlying atrial rhythm. So it's never wrong to try the adenosine. Often we'll do it, and then you see, oh, there's flutter waves. Now I go to the cardizem. But just having that in your back of your mind when you think it in an elderly person or older with just no history versus, yeah, I was ablated 5 weeks ago for SVT, then they're probably SVT. And they have a left bundle. It's going to look really weird, and it'll look like VTAC. So you can get AFib that look, so back to that one. If they had a left bundle in that, it's going to look like VTAC. So then you give some cardizem, and you slow them down into a flutter. So that's that whole SVT with the Barron-C where it'll look really funky. So when in doubt, adenosine, you can't hurt them. Yep, you can give it. Probably won't do much. Might slow it down a little, but you're not going to convert them out. Right, and it depends, Right. Yep. Yeah, you can convert them out of the AFib and they through the clot, but their stroke is diagnostic. So, 76-year-old male with chest pain. Dizziness and chest pain. What's this one look like? Adam. Yep. So this is your classic VTAC. It's regular. It's wide. So what are you going to do? They're talking to you. They're sitting there saying, I just don't feel so great. What are you going to give? What might you try? Okay. Yep. You can try some amio. Now he gets sweaty. Give you amiodarone, it doesn't do anything. He gets sweaty. Complains of chest pain. Now what do you do? Yep, you warm up the electricity. Is it synchronized or unsynchronized? Very good. Synchronized cardioversion, amiodarone, or bring in. Okay, so that's kind of our basic rhythm review, kind of getting through all your basics, blocks, access, rhythm, rate. Now we'll go into the National Registry requirement of MI and acute coronary syndrome. So we'll go through diagnosis and treatment. Here's my nice pretty color version of your leads. Everybody should pretty much have this memorized by now, but just remembering your inferiors, your anterior septals, and your laterals, and you'll go back and pick up lead 1 in your lateral. And this is kind of the lead. We'll talk about this one later. Really doesn't play much except for one scenario, and we'll talk about that here in a little bit. So, vessel anatomy. This is in the majority of people. Lots of people have weird offtakes and more main or more dominant left or right. But just kind of looking, here's your LAD and your right coronary. and your branches off come your circumflex, and then your left main coronary. So just kind of a view of what vessels, so you can have a visual when you're seeing on your 12 lead. So your right coronary supplies blood to your right atrium and posterior surfaces of both ventricles in your right coronary, in most people. Again, some people can have a right coronary dominant, left coronary dominant circulation. And your left supplies to both left atrium and left ventricle, but again, less of the posterior surface, and it branches into the circumflex. So your circumflex, right and left, are going to be the ones that will cause your biggest changes besides your left main on your EKGs. So just understand the pathophysiology of what happens. You get an artery that can't supply enough blood to the heart in response to the demand. So whether it's just because at resting they can't supply enough, or they're sick and their heart rates increase because they've got pneumonia and sepsis, and you can't supply enough oxygen through those narrowed vessels from all their plaques. So it doesn't always have to be a big clot sitting in there. It's just not enough flow based on the demand of the myocardium. So within 10 seconds, myocardial cells experience ischemia at onset of that need of increased demand. If they can't get enough oxygen or glucose, that's when they get ischemic. Those myocardial cells have decreased electrical and muscular function, why we start to see bundle branches and blocks on our 12 leads. Then they convert to anaerobic metabolism. Those cells produce lactic acid. Just like when you go work out, your muscles hurt afterwards, it's all that lactic acid. That builds up in the myocardium. That's bad. Pain develops from all that accumulation. That's why they get the chest pain. It's not the initial ischemia. It's that lactic acid building up in the heart that causes that pain to happen, just like it happens in your peripheral muscles when you work out too hard. So they have anginal symptoms until you increase the oxygen supply and meet the demand of those cells, whether that's through a stent, whether that's through just delivery of oxygen, whether that's through vasodilation with drugs. So why do we see EKG changes? How can we pick that up? So there's a difference between a subendocardial injury. Those are your ST depressions. So you can see this is what your EKG looks like when it's just this partial layer. Because it's still going through the normal pathway out here of the electrical conduction system, but not into the subendocardial. Versus when you have a complete, full-thickness transmural injury. Now, that conduction system doesn't work. It takes longer to depolarize and get through. Therefore, you get your ST elevation. So elevation equals acute infarct. Depression is ischemia. You can also see T-wave inversions and pathological Q waves after an MI. So if you see a new Q, it's done. It's over. They've already had their MI. So that's due to complete change in the morphology of their QRS complex because that cell's dead. It cannot go through the normal conduction system, so you get the Q waves, widened QRSs. So doesn't really matter. These are going to be the two things that cardiology is looking at. Do they need an embolectomy, remove this, or do they just have a thrombus and they need to balloon and stent? Doesn't really matter for us. Treatment's the same whether they're a thrombus or an embolus. It's blocking and it needs fixed. So I'm going to look at some 12 leads here. What vessel is involved, or what region of the heart's involved? So you've got ST elevation in 2, 3, ABF. And you've got some nice reciprocal changes here in V2, V3. So inferior, right? What do you want to be cautious with here? Right. So what happens if you load them with nitro potentially? Yep, going to bottom out their blood pressure. So we used to say do a right-sided EKG, which is still in the protocols, which means flip V4 over to your right side and see if you see reciprocal changes there. New literature says nitro is not improving outcomes, may or may not be helping much with pain in these. So if you have an inferior You can do the right-sided for your academic purposes. Just don't give the nitro. If it's inferior, don't give it. Because we're not improving their survivability. We're not improving their post-cast EFs or anything like that. So used to really, really harp on the right-sided or the posterior EKGs. Just don't give it if they're inferior. I'm not going to give it in the ER unless they've got a blood pressure of 200 and they're crazy hypertensive. That was the only time that I would try it, and I would have my IV and a fluid bolus ready. Because I've seen them go from 180 to 80 with one nitro. And then that's diagnostic. Then you can do some fentanyl or morphine. Yep. So I'd rather see you get this 12 lead and just give them 100 of fentanyl if their blood pressure can tolerate it than giving them a sublingual nitro and bottom them out. And now we're trying to battle back and loading them with fluids to get enough pressure out to perfuse the brain before we have to add. And the worst thing to do is add pressors on because we've given nitro to an MI. What about this one? What region of the heart? Yep, so you've got 2, 3, 4, and look at your inferior. Nice depression over here, reciprocal changes. And for some reason, this is a V1, tracing on the bottom instead of lead 2. So, anterior septal MI. What are you going to give this patient? Nitro. And what else? And there you go, aspirin. You know, the basics. And that one that popped up. So, where do you see your elevation in this one? Fortunately, the answers showed up. I'm supposed to trick you guys on this one, but. So why is this one a left main since the answer is down there? So that one lead I told you don't really look at a lot. Look at that. Look at ST segment elevation and AVR. And you get some kind of downsloping depression in 1, 2, AVL, little changes in 3. So you kind of have some diffuse ischemic changes, right? And now you have this kind of weird look in ST elevation and AVR. This is bad. Doesn't look that significant when you just glance at that 12 lead, but CN elevation and AVR can mean a left main. These are the guys that you send to the floor for their chest pain rule out, and you get called because they VFib arrest. So, oops, looking at AVR, when you kind of have some diffuse ischemic changes, can mean a left main. And I've had a cardiologist not want to take a patient to the cath lab, sat on him, waited until he VFib arrested, got him back, and then took him with a left main. So those kind of new studies are showing those are bad looking EKGs, although they're not the pathic tombstone lookings. Okay, 36-year-old male. He had 20 minutes of chest pain, called 911 when he was having the severe chest pain. By the time you get there, get him hooked up to the monitor, he is pain-free. What do you see? So what do you see here? Kind of some little bit of baseline ST elevation here. Definitely not tombstone looking. But look at your T wave. What is that? Going in both directions. So you have a biphasic looking T wave. So it goes down and then up. not normal, right? So these are often EKGs you'll get when they are pain-free. That's called Wellenstein. And these are often young males who are pain-free by the time you get there. Again, bad, bad, bad sign. This is why the pre-hospital EKGs mean something, because if you guys show me that, and by the time they get to me 25 minutes later and I don't see that elevation and those biphasic T waves, I might check a couple labs and send him home. But if I saw that pre-hospital EKG, I'd be calling cardiology. And they'd laugh at me and rule him out and then stent him later. But biphasic T waves in V2, V3, some mild ST elevation, they're often going to be pain-free because they had an event, and now we're seeing the reperfusion of the myocardium when you're getting them. So they don't have the pain anymore. Lactic acid's going away, pain-free, but they have a proximal LAD lesion. So, again, the reason to show us and make sure we see those kind of unusual, bad-looking pre-hospital EKGs, because we may not see that by the time you get them to us. And that's why a lot of these get missed, because they are pain-free by the time they get to the ER, whether they came in by pre-hospital or came in the front door. We get a 12 lead and they look good. And then they'll go on and have another event 2 days later and have a cardiac arrest. This one's circled for you because I couldn't find one without it on there. So 39-year-old male who passed out. Okay. Was just walking across the parking lot and passed out. So, again, all these kind of bad ones, you're looking in the middle of your EKG. So V1, V2, you've got some ST elevation with deep T wave inversions. Anybody know what this is? Yep. So this is Brugada syndrome. Strong work, Adam. So you'll see that right bundle branch block. Go back to your, so you've got your little rabbit ears with your RSR prime. So there's your right ventricle, your left ventricle, or your left ventricle, then your right. This is, and then you get your ST elevation. So this is an autosomal dominant mutation. This is kind of what you see, those family history of sudden cardiac deaths often can be, other congenital things, but Brugada is one of those that they look at. This is one of those things that why they talk about getting 12 leads for any family history in kids before they play sports, is do they have this congenital anomaly that'll cause VFib, VTAC, and sudden cardiac death. These are the kids that go down, young, healthy people. They don't have any signs of chest pain, ongoing. They just go into this rhythm, and they go into VFib, and they code. And you can induce it in the EP lab if you have, to send them there, and they all need an AICD. So if they have a family history of it, and you can do genetic testing if you have a big family history of sudden cardiac death in young people. Mm-hmm.
How strongly do we have to advise people to come start with that?
So if you see that, tell them.
And then if the DOT or passed out.
And he had that looking EKG?
I told Burns that. He told me to hand the phone to the guy.
Uh-huh.
So I was wondering how.
Yeah, so I mean,
You want to go to the hospital.
right. So obviously doing everything you can to convince them to come, and if they're reasonable people that you can explain the science a little bit of saying, this is a rhythm that's known that you'll just die. There's no warning, you collapse. So everything you can to convince somebody with any of the, besides your obvious STEMIs, most of those patients aren't going to fight you coming because they feel bad. But these patients, they may not have much symptoms by the time you get there. They just pass out and they feel fine when you get there. This guy, he's pain-free. He's not wanting to come. He feels fine now. These are the guys, though, that you have to try and convince, and when in doubt, call us, get us the 12 lead, and let us have that conversation with the patient to say, these are bad, bad things, and you can be dead in the next few weeks if we don't treat it.
Would you like to speak for 12 leads on this, like, so it's at the time that are going to be?
I mean, it would be a good idea. to kind of get in the habit if they'll let you get it, and you don't have another obvious cause. It's not like I just donated blood and I looked at myself and got up and passed out. But those unexplained syncope, the no prodrome, are the ones that we really need to be. The non-prodromal syncopes typically have something bad, and we should at least try and convince. Those are typically because they're hot and they're standing there and they vasodilate and they're on their meds and go down. Those are less concerning than the guy who's just standing at the checkout counter, down he goes, he wakes up, he's fine. You know, you don't have any explanation for it. But if you can easily explain it of, I donated blood, I've been vomiting all day, I'm hypotensive, I just took my blood pressure meds and forgot to eat, those are different. But these young, healthy people that have no explanation and just pass out, that's typically potential badness. So when in doubt, if you can get them, at least come out to the truck and do a 12 lead before you release them would be optimal. Realize not every patient's going to let you. At least document that you tried. So they come back as a cardiac arrest a week later, we can at least say we tried. Get back to where we were. Oh. So basic treatment, we've talked through most of this. Aspirin, why do we give it? It actually reduces mortality. It's the one thing we can do. The only thing we can do that reduces mortality in acute coronary syndrome. So it just blocks more of that inflammatory changes. You can go through the biochemistry and all of the cytokines and the inflammatory changes that happen in that vessel. Just give the aspirin. If they haven't taken it within the last 12 hours, give them the aspirin. Oxygen, we talked about this. Only give them if they're hypoxic. There's a big trial. It's called the AVOID study. I think it's almost a 10-year-old study now. But it showed that if you gave oxygen to patients that had a pulse oximetry reading of greater than 94%, their lab CPK levels were higher, which meant more muscle breakdown, and they had larger MIs when they got cardiac MRIs 6 months later. Huge trial, lots of patients that were cath stented, ballooned. So if you put them on 100% non-rebreather, had their pulse ox at 100%, they did worse. Yes, Phil?
So obviously, it's 911 call we have.
Right.
What would you suggest? That a lot, right? It doesn't matter how acute it is, whatever. Everybody comes out of there. We have guys here that are like, well, that's how they do it. Going off of
Right.
what, and just protocol.
Right.
They're 94, they're 94.
Right. So I wouldn't pick the fight with the cath lab nurse or the cardiologist. But if you're transporting them down to Mercy or something.
The problem I have is like, yeah, I see them on oxygen, so I always ask, oh, what around oxygen, what was your stats before it, or what was the oxygen?
Right.
Or we just did it for, they'll tell you, oh, they're 98.
Right.
Before we put them on, so it's like, then you kind of have that awkward, like, I'm not going to connect it to mine.
Right.
I guess you can connect it, just not
Turn it on. Right.
So that you have to do that, but I guess what I'm asking is pull back on our
Protocol. Yep. And unless they're on a balloon pump and they're being managed completely differently or they're LVAD, then yeah, just titrate them down. If they're on 6 liters and they're set 99, 100%, try and get them down to 4 or 2 liters, just enough to maintain that. And if they were, they were 99%, but we gave them oxygen anyway, just don't hook it up and turn it off as soon as you get in the rig. Right. Yeah, because, that's what we used to do. When I started this 15 years ago, everybody got a non-rebreather and lots of oxygen, and we thought we were saving them. Turns out, we were making them a lot worse. Just like many other things that you guys will see in your career that we used to do, and now we decide that's bad. So nitro, we talked about not in an inferior MI. Decreases your preload, so there's less blood to pump to the lungs to get oxygenated. If they become hypotensive, you give them fluids. And again, new study shows we are not improving morbidity, mortality at all with nitro. It helps their pain potentially, but we are not doing anything to change their outcome. Opioids, so they're inferior or they're a little bit hypotensive, give them some fluids and potential small dose of opioids rather than your nitro. 50 of fentanyl is going to drop their pressure a whole lot less than 1 sublingual nitro. So when in doubt, you can go with the narcotics if they really are hurting and need some relief. So beta blockers, they're in our protocol, and if you guys want to pull out your protocol, it should be with the handout I gave you. But beta blockers are in there. Back in 2013, when we updated these protocols, and then again in 15, there was still the thought that beta blockers were going to improve if we got that on board right before cath lab. Studies now show you have plenty of time. They need it after. You know, after their MI for at least 6 months to show improved outcomes, long-term benefit. Prevents another one. It does nothing to really prevent any increased damage at the time. So it used to be, get your 3 nitros, get them on high flow oxygen, and give them 5 of low pressure times 3. Get that all in before they go to the cath lab. Now, and you'll see Plavix in there, Brilinta, all the other new antiplatelets. That's the whole mission lifeline that's agreed upon by the whole state when we're taking MIs to the cath lab is beta blockers aren't fixing them, high flow oxygen aren't fixing them. Get their 12 lead, get their aspirin on board, and if they're in interfacility, we're getting the antiplatelets, so the Plavix or Brilinta. That's a mixed bag between cardiologists and cardiothoracic surgeons, because if they have to go to CT surgery, they can't have antiplatelets on board for a few days. So that's for cardiology and CT surgery to work out, but currently the standard is get that on board. And statins, long-term, even if you don't have that high of cholesterol, after an MI, you go on a statin. That is the other thing that's shown that it prevents future MIs. Questions? We may look at working with our cardiologists until our cardiology group gets settled here. I'm not jumping on putting the platelets on because we have one cardiologist who really wants them, one who's not as convinced, and we have a third interventionalist potentially coming in the next couple months. So once they kind of agree upon what they want pre-cath, then we will. Otherwise, try and get it potentially on board for if you're transporting to Des Moines, since they want that on board before. Otherwise, they're stopping to give it in the ER. So we'll probably look at. Question is, you know, we do Plavix here a lot. Des Moines is really pushing the Brilinta. So will we carry both, and will we do it? And everybody has their triple dosage, single dose. So until we get a little more settled out with the state protocols and our guys, I'm not pushing it, so we don't give it, and then they need CT surgery. Are you aware of these green STEMI bags that are on? Is that the labels and stuff to go to, so that they identify them at the Des Moines hospitals? I knew we put them on because that's what Mission Lifeline is, that group that's pushing it. It's basically a group of all the docs who are at, it includes ER and cardiologists that are at 24/7 cath labs. I've been involved a little bit, but because we're not 24/7, I don't have as much say. I guess I would assume it's either way if they haven't been cathed here, because they need to identify that they're going straight to the cath lab from here, because you're still trying to meet their whole point of that is meeting, just like our door to EKG and our door to CTs and our door to TPA is their door to needle time for their stents and identifying those patients. It's just another marker, but we probably should be doing it for interfacility transfers too. Cath lab.
RER, you know, and they're like, well, we haven't got the 12 lead. Well, I haven't taken one since, you know, so I guess going off of that, serial 12 leads what's your opinion?
Right, I mean, they should be getting the 12 lead from us and the ED sent.
I don't know what they ended up getting it before we got there, but I was like, okay, I'll do one right now. So
Right, and sometimes where we're sending them and who you're actually talking to, we may have sent it to the ED and now you're talking to the cath lab, or we sent it to cardiologist on the phone that said to send it here, and then you're talking to a nurse that doesn't know it's been gotten. But so unless you're seeing changes in their vitals or their rhythm on the monitor, a repeat 12 lead isn't really going to show you anything. But I guess if they can't get ours, then you can do one and transmit it. But it may be normal by the time you do one because we've vasodilated off the preload enough and fluid them that they don't have ST elevation anymore. Right. Any other questions? So looking at our protocol as we update it, likely pull low pressure. We'll just won't pull it from the truck just because you never know what some other institution's going to request potentially, or if you have an AFib or VR that you want to treat. But we'll probably take that out of the protocols for acute MIs and kind of just clear inferiors, no nitro, rather than do the right-sided, do the posterior. Really doesn't matter. Don't give it to inferiors. Any other questions on our protocols? Thoughts? Concerns? All right. Why don't we take a little break for a while? You guys go stretch.